Oops, sorry.
All right. Thank you for giving me the opportunity to talk to you on behalf of Susan Wong, who couldn't be here as the investigator for this project, about the ethical supplement and the survey to assess common ethical framework for low-risk comparative effectiveness activities in the hospital setting. So as a brief overview of the project, one of the objectives was to identify whether a common ethical framework exists for certain types of low-risk comparative effectiveness and studies of healthcare operations. Generally, these also are looked at as quality improvement initiatives, and we wanted to see survey IRB chairs, leaders of healthcare quality improvement programs, and patients to assess their attitudes and beliefs about informed consent requirements and risk assessment for these type of interventions, whether they were designated as a research or a quality improvement initiative. And we employed a number of common constructs that would be evaluated across all three of the surveys. We are in the process right now of data collection, so we don't have any preliminary findings to share with you, but I thought I would just go through some of our survey constructs and what we hope to be getting at the end of our data collection. So Susan Wong, as I said, is our investigator, and this is our investigative team and liaisons. So our project aims involved three surveys. The first survey would be of patients in a hospital setting. These surveys are currently underway at two academic medical centers, one at Brigham and Women's Hospital in Boston and the other at UC Irvine in California. And we've developed and conducted a structured interview, administered survey of patients in the hospital to evaluate what their expectations are for consent for a variety of low-risk hospital activities that are related to changes, studies about the changes of care, and that related to comparative effectiveness or healthcare delivery studies. And embedded in the patient surveys, we also included questions on how to evaluate effectiveness of phrases that would communicate that hospitals are dedicated to improving medical care and that participating in quality improvement initiatives and research helps improve care. And in that, trying to to understand how we could best express or a construct of a learning medical community. The survey of directors of QI programs, we were trying to assess the range of QI activities being conducted with and without a research premise to provide a context for ethical oversight of the studies. And we used the same constructed examples that we had, or very similar ones, in the patient surveys to explore the ethical boundaries related to quality improvement research and also their assessment of risk, consent, and waiver of consent. The IRB chairs, again, we were really interested in looking at their experience with an interpretation of minimal risk research activities involving quality improvement research as it relates to a waiver of consent, and we used the example scenarios to assess a common range of IRB determinations that are applied in these scenarios and evaluate if there are common drivers of risk determination and consent requirements. So the hypothesis here is to see if we could identify a threshold of risk. Is there a threshold of risk on projects below which operate under the same principles where patients felt that obtaining informed consent or documented individual informed consent was not necessary for a certain type of activity, regardless of whether it was a research project or if it was a healthcare quality improvement initiative. And the surveys were designed to see if we could find what that threshold is. And the questions that we addressed to patients were whether or not they would want to be asked their specific permission or written permission for a variety of activities that are very common activities in the quality improvement arena in hospitals. And from this, wanted to see if we could get a single ethical or develop a single ethical framework for evaluating routine minimal risk studies that evaluate healthcare changes in healthcare delivery. And the things that we were looking at is were these scenarios where both IRBs felt that it was appropriate to waive consent, and whether patients felt that they did not need to be asked for their prospective informed consent for these types of scenarios. So the question of how to evaluate the consent. In the patient survey, questions were structured about whether getting their permission, or providing permission was necessary. In the IRB survey, we looked at whether types of studies were eligible for a waiver of consent. And on the QI survey, we wanted to ask if it would identify reasonable and feasible QI studies within the hospital setting. And in the survey, there was a number of subconstructs of questions, and they ranged from things that talked about environment and did not touch the patient. These were actual scenarios of things that did not touch the patient, and then increasingly became where we felt we would see more that people might be more concerned about wanting to be fully informed. And then we wanted to address data sharing, attitudes about data sharing, and changes in policies and procedures at hospitals. And these subcontracts were developed along all three of the survey lines. So for the hospital environment, these are the types of questions that we asked. We were looking at, do you want to be asked your permission if the hospital is looking at different ways to reduce noise level at night, and these various types of things. And then in the category, we moved on to questions about products that are used on or by patients, to medication, comparing medication and devices, and for that we looked at comparing use of generic versus brand name drugs, different types of blood drawing needles or methods of drawing blood, and things of that nature. And on the policies and the procedures, we wanted to look at whether it made a difference to them that they were informed about trying out different post-charge teaching materials or education methods, or closing surgical incisions. So there's a variety of different things within each of the subconstructs, so that we were trying to get the attitudes and opinions of our key stakeholder groups. We thought while we had the opportunity to ask the questions, we'd also like to get their views on data sharing, and so our surveys included scenarios involving some of these types of data sharing. So the response options on our surveys, for each of the questions, we asked specifically to the patients, would it be okay for the hospital to go ahead without your permission to compare ways they might improve care? So we started with some very general questions on the front, and you could see that's the range of response options. As we moved through the survey and got to the individual constructs, we asked about making with more particular scenarios, we ask about making changes in the hospital environment, and if you would like to be asked your permission before hospitals can make changes in patient care that affect, and then we went through the various scenarios. And for those, you could see they range from definitely yes to definitely not, and asking, would it be okay for the hospital to go ahead without your permission to compare ways they might improve care in these following scenarios? And the same pretty much ran through the rest of the subcontracts. Our next steps, as I said, the patient survey is underway right now and we are collecting the data. We hope to be completed with that by March of this year. Both of the QI survey and the IRB survey has been approved by the IRBs, and they are getting ready to launch early January. And so we hope to see some data in the spring on what we feel are these very important questions that relate to comparative effectiveness in delivery care, the study of care within delivery systems. The QI surveys and the IRB surveys also really address questions related to the effective randomization and whether that would change their opinion in terms of risk.
For those who weren't here yesterday, just to remind you, these supplements were given to do research at a time we didn't know the guidance was going to come out or there would be a meeting today. So Sheila had a tough job of presenting, leaving us in anticipation of what the results will be, and I think you did a great job with it. I feel compelled to mention, Scott, while you go up, just that this work is sort of derivative, in my view, of the research being done in the Healthcare Systems Collaboratory and its precedent work where HCA, together with the academics, has randomized hospitals. And their first study was a revolutionary finding. 7 states already had laws requiring a certain approach to preventing MRSA that were clearly wrong once the research was done. But many of us, imagining that it was hundreds of thousands of people getting individual consent to participate in this would have been a pretty amazing challenge. And they have a second study now as part of the collaboratory. And also noted your surgical incision example. One of our best papers was a New England Journal paper on surgical sponges, where there were sponges already on the market in wide use that were thought to be antibacterial that actually increased the risk of infection when we did an RCT. So this kind of research, while it looks like there's not much at stake, can have a huge impact.